Hi, everyone. So we're going to get started now. And if anyone, obviously, if you're having trouble with the sound, you won't hear me say this, but I will do troubleshooting for any sound issues after I do my introduction. So Dr. Cassidy, can we just check and make sure we're good to go with your sound again?
Hi, Megan. Can you hear me okay?
Yes, sounds great. Excellent. So let's get started. So we have with us today Dr. Christine Cassidy, and the title of her presentation is Working Collaboratively Within the Health System, Lessons Learned from an Embedded KT Scientist. So welcome everyone, welcome Dr. Cassidy. I hope everyone is keeping well through all of this. So Dr. Cassidy will be presenting for around 40-45 minutes, and then we'll have about 15 minutes or so for Q&A. So if you do have a question, feel free to type it via the chat box. If you type it to everyone, then everyone will be able to see it, which is sometimes helpful, but if you would prefer to type it just to KT moderator, that's me, and I will read it out. I'll read them all out regardless if they're to KT moderator or to everyone. Everyone has been automatically muted, just to let you know. So Dr. Cassidy is a registered nurse, assistant professor in the School of Nursing at Dalhousie University, an affiliate scientist at the IWK Health Center. She received her Bachelor's of Science in Nursing from the University of Prince Edward Island and PhD in Nursing from Dalhousie University. Most recently, she completed a CIHR Health System Impact Postdoctoral Fellowship at the IWK Health Center and University of Ottawa with the Integrated Knowledge Translation Research Network. Her program of research uses an IKT approach to design, implement, and evaluate evidence-based practices and knowledge translation interventions in pediatric care. So thank you for being here, Dr. Cassidy, and I'm going to pass it over to you.
Great. Thanks, Megan. Good afternoon, everyone, and good morning to those of you that are further west. Thanks for that introduction, and thank you, everyone, for joining me today. I'll echo Megan's comments and hope everyone's staying both physically and mentally well and staying home as much as we can. I feel quite fortunate to be able to present today from the comfort of my own home. And although this topic specifically isn't COVID-19 related, I am hopeful that some of the conversation that we'll have and what we'll discuss will showcase how important research partnerships are, especially in the middle of a crisis like we find ourselves in at this moment. But to build on that introduction that Megan provided, I want to give you a bit more context on my academic journey. So I am a registered nurse. I graduated with my BSBN from the University of Prince Edward Island. And after graduation, I worked on an adult surgical unit at the QEH in Charlottetown before I moved to Nova Scotia to start working at the IWK Health Center, which is a women's and children's hospital here in Halifax. And I started working there on a postpartum unit and also started my graduate studies at Dalhousie University alongside that. My PhD work at Dalhousie was focused on designing behavior change interventions in the context of university students and their use of sexual health services. After I graduated, I then completed a joint postdoc fellowship at the IWK Health Center and the University of Ottawa before I made my way back to Dalhousie last fall, where I started as an assistant professor in the School of Nursing and an affiliate scientist at the IWK Health Center. For my presentation today, I plan to address three main objectives. I want to give you an overview of my own work in using an integrated knowledge translation approach to address knowledge to action gaps in pediatric care. And from my own experience and from what we're learning in the literature, I'll go through a discussion around a series of strategies that hopefully you can employ in your own work to be an effective research partner in the health system. And then lastly, I'll discuss some of the areas of focus that I see moving forward for future directions for collaborative health services research. I attended these KT Canada seminar series throughout my graduate studies and continue to do so, and I've learned so much about KT and KT science from this work. So I'm hoping that for those of you that are graduate students attending this session especially, that this will be of value to you in that way. I also have always loved these seminars for pointing me in the right direction for literature to be reading, so I hope to do a little bit of that too. And I also want to note, I had originally planned on hopefully co-presenting today with one of my health system partners so that you could hear their perspective and lessons learned as well. We've done similar presentations together in the past. But of course, given the current context, there are much more pressing priorities. So I ask you to keep that in mind, that what I'll be presenting today is from my perspective as a researcher and a registered nurse. And while I'll do my best, missing from the conversation is the voice of the health system in terms of this partnership discussion. All right, so we can get into it here. So there are so many different terms that are used to describe collaborative health services research. And broadly, they all focus on researchers and health system partners working together to understand and address complex healthcare problems. I'm going to use the term collaborative research, collaborative health services research broadly for this presentation, with more of a focus on integrated knowledge translation. And so I'm not going to go into great detail about the differences and similarities between and amongst these concepts, but I will, however, point you to a new paper that goes into this in much more detail. It was just published, I think, last week or the week before by my colleague, Dr. Tran Nguyen, and it goes into great detail about the different collaborative research approaches and compares them to integrated knowledge translation. But really, all of these approaches are trying to do what we focus on in knowledge translation and bridge that know-do gap, the bridge between what we know and what we do. Because this gap is impacting a variety of different outcomes, patient health outcomes, outcomes related to healthcare providers, the health system, and overall population health. So really that quadruple aim. And we know that the health system is a complex system with multiple interconnected and dynamic factors that influence this evidence to practice gap. And so it's really not as clear cut as my bridge image makes it seem on this slide. Related to that complexity within the health system, we often have transfer problems. So meaning we don't do a very good job of transferring evidence into the hands of those that need it. But where I like to focus a lot of my work on is also this production problem. So maybe we have this gap between evidence and practice and policy because we aren't asking the right questions and producing relevant evidence that can be used in practice and policy. A strong collaborative research partnership can aim to address both those transfer and production problems and hopefully start to unpack more of the complexity of the healthcare system. And so there's been some work done looking at, a range of benefits of when we work in collaboration, including greater relevancy and credibility of the findings, more value for research among decision makers. We're building capacity of both researchers and knowledge users, those within the health system. And when we work in this collaborative approach, there's a greater likelihood that the research evidence will be applied in practice. That's a very brief overview of collaborative health services research, what it aims to do, some of its proposed benefits. But I want to start by taking you through my journey with integrated knowledge translation and how this has helped me to build my program of research. And then we can get into more of some of the strategies, lessons learned, and where we should be heading next. So my IKT journey really dates back to 2015, when a clinical team at the IWK Health Center formed a partnership with the SITC lab. This is the Strengthening Transitions in Pediatric Care Lab, which is a program led by my PhD supervisor, Dr. Janet Curran. So the clinical team at the IWK found that they were taking a fairly status quo approach to practice and policy change. They would have a series of adverse events on their unit. They would take a look at those events and realize, okay, something needs to change. So something would be pushed from the top down in terms of changing something to address those adverse events. After that change was implemented, it would oftentimes fail. So back to the drawing board, rinse and repeat, and they would try again. And the manager on the unit reflected that they had been going down this road time and time again, and they noticed that there really was a gap between evidence and practice, and they somehow needed to bridge this gap. So this team from the IWK attended the Real Change Intervention Workshop Series. This was a year-long KT capacity building initiative where teams were partnered with a knowledge translation coach, and they were guided through a series of stages to apply KT principles to their practice and policy change issues. This workshop was led by my PhD supervisor, Dr. Janet Curran. And like any good PhD student, when your supervisor says, hey, you should come to this workshop series, you show up. And so I showed up with my implementation science toolbox as a junior KT coach. And I was paired with this team from the IWK Health Center. And together we used an IKT approach where the expertise that I brought was some of the methods and frameworks from my toolbox. We applied them to a particular practice change problem, whereas other members of the team brought their clinical expertise and understanding of the culture and context. We used those expertise together to address some different healthcare problems that they were facing. The team started to see the value in this systematic approach, and after the year-long KT workshop concluded, they hired me as a part-time embedded researcher to work with them beyond this workshop series to continue this process of systematically applying implementation science frameworks and methods to their practice change questions. As I started my work as an embedded nurse researcher on this unit, we worked together as an interdisciplinary team where, as I mentioned, each team brought a different expertise to the table, and we would walk through the stages, sometimes forward and back, of the knowledge to action cycle to address problems that they were facing. It oftentimes started with reviewing their patient and health system outcomes to identify a practice issue. From there, we would go to the literature to select an evidence-based practice that would be appropriate to implement. We would adapt the intervention to fit the local context in terms of their structures and processes. We would conduct pre- and post-implementation barriers and enablers assessments guided by the theoretical domains framework. We would use those findings to tailor our implementation strategies alongside with the behavior change wheel so that we were addressing the barriers and enhancing the enablers. From there, we would roll it into practice and we would conduct chart audits and touch base with the team to understand their use of the intervention in practice. And we would also evaluate the impact of the intervention on different patient and health system outcomes. And then always be checking back, since we had this embedded model, to understand if this knowledge was continuing to be used and if it was sustained in practice. So checking in at education days and unit prompts, things like that. I really enjoyed applying these implementation science methods to real clinical issues and seeing meaningful change in my work. And I remember reflecting during my PhD studies that I would love for this to be my full-time job, continuing to just take teams through this cycle and applying these different methods to their practice change questions. I fell into this type of partnership research based on my training with Dr. Curran, and I could see the impact, firsthand that it was having on myself as a researcher, but also on my health system partners. And I did want to learn more about the science and the approaches to these partnerships, and I also wanted to understand more about the context in more detail. So beyond my part-time embedded role, I wanted to be even more embedded to understand how decisions are made and how practice is influenced. And so fortunately, there's a postdoctoral fellowship program just for that. So I completed the CIHR Health System Impact Fellowship Program, and this is a joint fellowship opportunity where you are paired with a health system partner organization and an academic organization. So at least 70% of your time is spent embedded in the host partner organization, and 30% of your time is protected for academic work. So this type of fellowship takes you beyond the research and analytical skills that you learn in traditional academic programs and starts to focus in on different types of professional skills that you would need for embedded research and to work in partnership. So this diagram here are the enriched core competencies that were developed by CIHR and their training modernization working group with CHESPRA. And so you can see on the left-hand side, it's more of those professional skills that you might not get in traditional programs, whereas the right-hand side are those classic research and analytical skills. My supervisors, Stacey Burgess from the IWK Health Center and Dr. Ian Graham from the University of Ottawa, we wrote about our perspective and experience with this type of embedded fellowship program and how these embedded structures really can foster that integrated knowledge translation approach. So you're putting partnerships into action and you're taking that IKT concept in theory and putting it into practice. And by creating that structure, it creates an opportunity for the science to take place in conjunction with practice. And in doing so, we're co-creating value for all members involved and organizations, the health system organization, academic institutions, and then myself as a fellow. Throughout my time in working with the IWK Health Center and the Children's Health Program as both a part-time embedded researcher and then as a postdoc fellow, we were able to continue to build on this partnership and work on a variety of different projects that were identified as key priority issues within the Children's Health Program. So a few examples are an early warning system, so a system to identify patients that are at risk for clinical deterioration and then intervening appropriately. A high dependency care model, so this is similar to a step-down unit. It's rearranging and reallocating nursing resources for patients that are higher dependency. And we also focused on handover, so transferring patients from healthcare provider to healthcare provider, and how can we make changes to that to improve that transition. Our work has led to important outputs from an academic and a health system perspective. The IWK Health Center's Accreditation Canada review occurred in 2019. And at that time, the review identified these two interventions, primarily the early warning system and high dependency care model, that we implemented were major strengths in the Children's Health Program. And we've also had several publications from this work with others in the pipeline. And so it's rewarding to see that this work has impacted the academic community with traditional academic outputs such as publications and presentations. But it's also improving patient care and being recognized from an accreditation perspective, which is really important for the health system and health system leaders' perspective. I think this demonstrates that there's value to collaborative work for all members involved. I often sometimes describe this as behind-the-scenes science. So while we're implementing something that has been identified as a priority to the health system and they're getting value from that implementation, is there some type of KT science question that we can also address alongside that implementation? To put that into a little bit better context, I'm going to use one of our implementation projects as an example to highlight how we co-create value for both the health system and researcher perspective, and doing some of that behind-the-scenes science by embedding a KT science question within the project. So I'm going to use CHOOSE as a case study example. CHOOSE stands for the Children's Hospital Early Warning System. And following a series of adverse events, the senior leadership team at the IWK identified the need to detect clinical deterioration early and intervene sooner. So they identified the Children's Hospital Early Warning System, or CHOOSE, from the literature as a tool for nurses to use to identify patients at risk of clinical deterioration. And then it offers an escalation of care algorithm based on a stoplight analogy with guidelines for intervening appropriately. So you can see here on the right-hand side of my slides, that 0 to 2 would be considered a green, stable zone. 3 to 4, things may be escalating, so we need to consider, increasing frequency of vital signs, increasing assessment, and maybe considering a higher level of care. Whereas a score of greater than 5 would be considered that red zone, where we may need to activate a rapid response team or consider a code blue. Traditionally, this type of tool would have been just kind of thrown into practice, and the leadership team would often hope for the best. But because of this partnership that we were having the team said, wait a minute, let's bring in Christine to work on this project. So we did take our, integrated knowledge translation approach, systematic approach to guide the implementation and evaluation of this work. And the KT science question was more focused on how can we identify and compare factors influencing the implementation of CHOOSE on 2 different pediatric inpatient units within the same healthcare organization. This project followed the knowledge to action cycle, and we used a qualitative descriptive design with pre and post implementation focus groups and interviews with 53 nurses from 2 different units. We used the IPARS framework to guide the analysis and then applied a triangulation protocol to compare the barriers and enablers between the 2 units to understand where areas in those barriers converge, so they were similar, and where there's more divergence and differences between the 2 units. This results figure displays the findings also using a traffic light analogy. So green meaning things were going well in these elements, yellow indicates a mix of barriers and enablers, and red indicates predominantly barriers. So on the first unit, in terms of innovation and the recipients and the nurses using it, the nurses felt that the CHOOSE intervention fit with their current practice. They were motivated to use it because they felt it enhanced patient care and made them feel more confident in their decision-making. On unit number 2, this wasn't necessarily the case. So some of the junior nurses felt that it could be useful to help build their clinical judgment. Many felt that they didn't need the tool and they were already picking up on sick patients and intervening appropriately. So really this tool was taking away their clinical judgment. It was in the context domain where we really started to see some major differences. On the first unit, overall, things went quite well. There was some concern with physician buy-in, but there was a physician champion on that unit who worked with all physicians to help mitigate any concerns that they had.
Organization or whatever you do, your department, is faster than the rate at which you can change.
Sorry, I'm just going to ask that everybody mutes.
Natural selection and evolutionary biology.
Yeah, everyone should be muted.
And that's
Hang on
kind of what
sec.
worries a lot of people in healthcare.
There. Sorry about that. Don't know why that happened.
Megan. No problem. So as I was mentioning, really the focus on context. And so with the first unit, they had the physicians on board, the manager and clinical leaders were all on the same page and consistent messaging to their staff. And also the CHOOSE tool fit really well into their existing systems and processes and in terms of documentation. And even a staff nurse on that unit made a tailored documentation tool on their own time specific for the CHOOSE intervention. Again, this was not necessarily the case on the second unit. There was very limited physician buy-in. There were concerns with the nurses calling the physicians and then them not coming to see their patients based on the recommendation from the CHOOSE tool. The manager was very supportive, but overall, the lack of consistent support from all of the leaders on the unit. And when you looked at the documentation processes, it was very different than the first unit where it flowed quite nicely. On the second unit, they did their charting in a very different way at a very different time of day. So the CHOOSE tool was not as useful for them because it wasn't being completed in real time as it was on the first unit. And so this example just shows that we could have the exact same intervention implemented on 2 different units that really they're just down the hall from one another, but because of their context and the way that they work and their culture, they can have a very different implementation experience. And so throughout this work, we really started to see how relational it was and the different approaches that we were taking depending on the unit and how we had to change our approach for Unit 1 versus Unit 2. And so a question that stemmed for me from this work is really this concept of facilitation and the process of enabling or making easier the implementation of evidence into practice. And what facilitation strategies are helpful or not, and how do we tailor facilitation strategies depending on contextual factors. So something that I plan to pursue further in my program of research is understanding this role and process of facilitation when implementing evidence into practice. So that CHOOSE case study example I hope highlighted how I really do plan to structure my research program with two research pillars that run in parallel. So the first, really focusing on implementing evidence-based practice interventions, so using that IKT approach, working with my health system partners to design, implement, and evaluate evidence-based practices that they've identified as relevant, timely, and useful for the health system. But then alongside that, always embedding a KT science question to advance our understanding of how to implement evidence into practice and policy. And ideally, these two pillars will just continue to be a feedback loop of once we understand, more about how to implement evidence into practice, we can use that to inform pillar one of actually implementing evidence-based practice interventions. A few examples of how this work is coming to life and some projects that we are working on. In terms of those evidence-based practice interventions, my health system partners have identified a few key areas that we're focusing on, one being service delivery models for pediatric ambulatory care, improving the transition from pediatric to adult care. This is a project that was identified as a priority through the Maritime SCORE Support Unit bridge events. And so that's a great model that showcases bringing the key players to the table to identify practice or policy issues, and then everyone bringing their expertise to address the problem. And the last being a focus on designing interventions for nurses to use to address vaccine hesitancy and or refusal among their pediatric patients. So those are some examples of the practice change interventions, whereas the second pillar more focused on implementation, KT science. A few examples of the projects we're working on. We're currently conducting a systematic review on implementation interventions for when we implement and disseminate nursing guidelines. And also working to advance, as I mentioned before, understanding of that process of facilitation and the role of different facilitators during the implementation of evidence-based practices. So that's really brings us to my focus on this second learning objective. And I want to have some type of conversation really around how to be an effective research partner. And I pulled this together based on my own experience from working within the health system, as well as what we're learning from the literature on this topic. I think it's important to note first that while there are many proposed benefits to collaborative health services research, it's not always easy, and I'm sure many of us have heard some of these challenges before. They are quite well documented in the literature, but it takes significant time and resources to develop trusting, authentic relationships, and there may be insufficient resources to support that development and maintenance period. Oftentimes, depending on the cultures and worldviews that we're coming to the table with, researchers and health system decision makers often have different values and priorities. And so this can sometimes lead to a mismatch of agendas, and there can be differences in power in those relationships, and kind of what are the expectations and what do we want to get out of this relationship or out of this project. There can sometimes be disagreement on the importance of the research findings, and as a result, maybe some conflicting interpretation of what to do with the results. And there's also been some conversation around rigor versus relevance, and the challenges with developing a study timeline that can meet the rigorous scientific process, but also respond to fast-paced decision-making process in the health system. I personally think this is a bit of a false dichotomy, and I think this depends on kind of your philosophical approach and what paradigm you situate yourself in. But my thoughts on it is a project or a study really rigorous if it's not relevant? And I kind of urge us to move beyond this division of it's one or the other and be more adaptable and flexible to the research questions so that we ensure that it's relevant and making an impact in the health system. A lot of the work, there has been a lot of work on the importance of meaningful relationships. There's a whole other literature around patient engagement and building positive relationships with patients. There's been a focus on the experience of researchers working in collaboration, but there hasn't been as much discussed around health systems experience with these partnerships. So health system leaders, health system decision makers, and their partnership with researchers. There was a group from the Integrated Knowledge Translation Research Network that sought out to understand this in a little bit more detail, and they conducted a national Canadian study looking at the experience and perspectives of senior health managers that are within health systems organizations and their experience with partnering with university-based researchers in Canada. This paper, I highly recommend it. It goes into some great detail around the findings of their experiences with partnerships. And there's a lot of rich findings, but I'm going to focus on 3 key themes that came out from this study. The first being health system leaders' perspective on research and its usefulness. So oftentimes they describe research they experience being involved with as unhelpful or often irrelevant in organizational decision making. So as a result, it was being given a low importance. They had different understandings of what research is compared to researchers. And so there was this lack of shared understanding around the different concepts of research, quality improvement, and evaluation. And they were all viewed as very different siloed activities. In terms of their experience as an organization, they found that the organizational stress and restructuring that often occurs does influence these research relationships, because then you then have to go restructure existing relationships. There was a lack of infrastructure support to support research partnerships. And kind of the one that I want to focus in on the most that I find particularly interesting is this concept of academic responsiveness and readiness to partner. So the participants discussed a mismatch of researcher interest with what the health system needed. They found that there was a limitation in researchers' readiness to work within that fast-paced healthcare environment. And this was highlighted with a lack of understanding of the health system context and a lack of researcher skills in conducting collaborative research work. Unfortunately, some of the participants also outlined some really stark examples of inappropriate researcher behavior, which influenced their willingness and ability to partner with other researchers moving forward. What I like about this study is that they also made a really strong call for multi-system change to reimagine research and make it more relevant and useful for the health system. Since this study was published last year, and in response to that call to reimagine research, there's been a lot of activity and commentaries in response. So I highly recommend that you take a look at this series for a rich discussion on what reimagining research could look like. I think there's 11 commentaries that have been published on this topic and in response to this paper. And some of the highlights from this conversation is that there's several strategies at multiple levels, individuals and teams right through to health system and academic organizations and the funding bodies on how we can be strengthening research partnerships, focusing on partnership research funding and advancing and improving peer review practices for assessing collaborative research, having strong leadership for partnership research at different organizational levels, and making it really clear the organizational processes related to supporting partnership research, and really considering the range of outputs, especially for academics and the kind of that academic currency. Can we really move beyond the publish or perish model when we're focusing on effective research partnerships? For the purpose of this presentation, I'm going to focus a little bit more of our conversation today on those individual and team level strategies based on, again, my own experience being part of a team within the health system, and then what we're also hearing about this in the literature. But I do encourage you to think about how we can move this conversation forward to address some of those higher level strategies as well. I think the first thing to focus in on, and we've heard this time and time again, is the importance of developing positive ongoing relationships. And one of the recommendations from that series of commentaries that I particularly like is the need to focus on research relationships. So not just project partnerships where you have a specific project in mind, and so you go out and find a partner for that project, but fostering an ongoing research relationship that maybe focuses on a research issue, and then sub-projects flow from that partnership. I think the second is really focusing on how can we reimagine both the role of researchers and the relationship between researchers and health systems. And what I mean by that is that when we adopt this practice of humility, we show respect for diverse perspectives, we aim to understand each other's context, and we're open to others' views. And so by adopting that practice of humility, we're no longer seeing the researcher as the only expert at the table, but instead our role as researchers is to learn, listen, and respond with our research expertise, but also in collaboration with everyone else's expertise at the table. When researchers work in this way that's guided by humility, we can strive to co-create strategies that respond to the struggles in the healthcare system and identify mutual gains for all parties involved. I think a lot of the time we focus on, okay, how can we get the health system to understand the value of evidence and embrace the use of evidence in practice and policy? But by focusing on co-creating value-driven work, we're shifting that and having the researchers and health system leaders align their shared goals and improve outcomes. I think in order to do all of this work, we need to be flexible and more of a service-oriented relationship so we can respond to needs. And in doing so, oftentimes more of a generalist approach. So less focused on, I do research on X and that is it, but more, this is the range of skills that I have and how can I help apply it to address a current, timely problem in the health system. Based on some of my learnings to date, both from being embedded in the health system and then, again, that ongoing conversation in the literature, I do envision several ways to move this work forward. Although I think there's many directions to go, I've narrowed it down for the purpose of this presentation, I think, to 3 key components for this conversation. And the first is really focused on making research relevant. So there needs to be more of a focus on, as I mentioned, being service-oriented and responding to health system needs, and in doing so, making research relevant. I love this tweet by Tricia Greenhall last week or the week before, March 20th. It speaks to that transfer and production problem that's often, referenced in KT. When we're in the middle of a crisis like COVID and we have those existing partnerships, then we can work together and ask the most relevant questions. Researchers can, bring their skill sets to the table, pull together the evidence, and then work with health system leaders and clinicians and patients to develop and change policy. And so I hope that we will continue to see a lot more of this rapid review methods and rapid review approach to respond to health system needs. There's a large group of us here in Nova Scotia, we range in researchers, health system leaders, patients, clinicians, administrators, and we are conducting rapid reviews on questions that come directly from decision makers in the Nova Scotia Health Authority and the IWK. And so we've conducted a rapid review on nursing role optimization in primary and emergency care. And based on those relationships, there's now a rapid review happening, in response to COVID-19 based on questions that are relevant. And so I think when we employ this more multi-method generalist approach, we can focus more on the skills that we have and that we can provide to the health system to address a range of research questions. So an example of that would be, you know, I'm not an expert in nursing role optimization. I'm not an expert in early warning systems and clinical deterioration among pediatric patients, but I can bring methodological expertise, and then my partners bring that content and context-specific expertise. So moving forward, we need to focus on developing those almost research program relationships that transcend multiple sub-projects and not just one-off research project partners. And there's been some really great examples of this work that's happening across Canada that shows the value of those research project partnerships, really. And when we use that approach, this allows for time to build, you know, maintain the partnership, conduct the work, see the impact, and then loops back and leads to another research question that the team can work on together. I think in order to make research relevant, we also need to advance how we are doing evaluation in a couple different ways. First, it's advancing evaluation methods. So as I mentioned in that Canadian National Study of Health System Leaders and their experience with research partnerships, they really did see research and evaluation as two completely different entities and two different things. And so how can we advance our understanding of evaluation and do better quality and more useful evaluation for the health system? What questions are we trying to answer, you know, and what methods and approaches will help us get there? This approach will allow us to be, you know, more adaptable and flexible. The developmental evaluation approach by Patton taps into the complexity of the healthcare system and using that adaptable evaluation approach to understand and enhance innovation or evidence use. There's also a way to and a need to advance the science of collaborative health research. So we know lots of proposed benefits, but how do we know what works, what impact it's having, and how it's working? So we need to evaluate and build the science base for collaborative research, and this is the focus of the Integrated Knowledge Translation Research Network. They are assessing, you know, the relationship between collaborative research and evidence use and identifying best practices and best conditions for conducting integrated knowledge translation. And there's a great series out just recently out of the BMC that highlights a series of concept papers to move this work forward and kind of where we're going with collaborative health services research. In order to make research relevant and apply different evaluation methods to complex problems, I really believe that we need to be trained to do so. And so these ways that I've suggested and some of these strategies that I've mentioned for being an effective research partner, we aren't necessarily prepared to use those strategies during our graduate studies. Most often, most commonly in graduate work, we find that gap in the literature. We put our heads down and we do our work, and then at the end of our thesis or dissertation, we put our findings together in some form of dissemination activity at the end. But most of us don't necessarily learn or get to practice the skills needed to work in partnership. And so going back to that concept of adopting a practice of humility, we need to create environments and spaces for researchers to learn about health system context and the role and expertise of all members, and equip researchers with those skills to work in partnership. We took the findings from that National Health System Leader Study and we partnered with the CASPR Student Working Group last year to create a workshop on this exact topic that we delivered at CASPR in 2019. And we published a summary of that workshop and our reflections as facilitators. And something that we found and reflected on is that those that are interested in collaborative research or already doing collaborative research, they're the ones that are showing up to these types of workshops and training initiatives. And so they understand the nuances and they understand how to work in collaboration. But we need to get equipping all health services researchers, not just those that are, you know, quote unquote, interested in collaborative research, and be able to prepare them to work in collaboration for all areas of health services research. So I'm going to leave you with those thoughts to move forward, I want to thank all of you for listening, and also thanks to some of my previous and ongoing collaborators of the work that I've mentioned throughout this presentation. And I'm looking forward to have the opportunity for some discussion.
Awesome. Thank you, Dr. Cassidy, for very relevant for the time and definitely for the future as well. So let's open it up to some questions from the audience. So if you do have a question, please feel free to type it via the chat box. As I said, you can type it to everyone, or you can type it to KT moderator, and whichever one you choose, I will read it out for Dr. Cassidy. So we'll just give people a minute for that. Was there anything you wanted to expand on that you didn't have time while we wait for, oh, there's the first question. Hold that thought. Okay, so from Elizabeth Keys, she says, great presentation and lots of links to more information. Do you have any recommendations for a resource or a tool that someone who is new to this should start with first?
Awesome. So as you mentioned, I have highlighted lots of references and things in the literature to explore, but in terms of more tangible tools, the Integrated Knowledge Translation Research Network has a website with some valuable resources on there. Also, the CIHR guide has a section on integrated knowledge translation that I have found really helpful as well to get started with collaborative research approaches. So I would recommend those two to start with, and then I'm sure as you get going, you'll find even more.
Awesome, thank you. All right. Oh, and okay, so Elizabeth has a follow-up question, and then we have another one from Katie Sibley. So Elizabeth's follow-up is also, what do you think are the most common misperceptions related to partnerships in research?
What do you think are the most common misperceptions? I think that one of the most common misperceptions, and I mentioned it briefly, was this dichotomy of it's either rigor or relevant. And I've had a lot of conversations about this with some of the other health system impact fellows, and kind of this struggle with, you know, we were all trained in an academic model. How can we be publishing and presenting and still doing important scientific work while making an impact to the health system? And so I do think that is a misperception, and we can still be doing, you know, high quality, rigorous work when it is relevant and useful to the health system. And so I think I would challenge that misperception moving forward when we discuss partnerships in research.
All right, thank you. And I've got another one here from Dr. Sibley. She says, hi, thanks for a great talk. In thinking about your case example and comparison of the two units, thinking about the context component, how did the clinical caseload or focus interact, or clinical caseload and the focus interact, I guess?
Feel free to correct me if I'm interpreting your question incorrectly, but I think maybe what you're asking is that there are two different units, so they do care for different clinical presentations. So one unit, you know, cares for a range of different services of the, you know, medical, surgical, neurology unit, whereas the other unit did focus in more on just kind of a medical unit. And so the presentation of different patients definitely played a role. And I think that particularly with the impact of the cases on the first unit, there was, you know, a more severe adverse event, and that adverse event was able to influence the nurses, I guess, motivation to get on board with the clinical tool faster, whereas the level of acuity on the second unit was a little bit more little bit more stable, and so they didn't see as much of a value or were as motivated to use it because of the clinical presentations of their patients. That definitely had a role to play in terms of the context of the unit and the services that were offered.
All right, thank you. Another question here from Dr. Jasmine Ma. She says, hi, Dr. Cassidy. Thank you for a fantastic presentation. I'm wondering if you've come across a scenario where the health systems leader you're working with to champion the initiative is very supportive of the research, but you learn their relationship with staff may not make them the most appropriate to lead the initiative.
Yes, that's a really good example, and I think that that's probably happened to many of you on this webinar, and it's definitely something that I've encountered before. Oftentimes, the recommendation is make sure you have senior level leadership to support your projects, because they're not going to go anywhere without that. And I do agree with that. Oftentimes, you need that senior level leadership in terms of resources and supporting staff to engage in an implementation project. But I really do take it a step further, and you need to have partnerships with almost every level. So yes, with senior level, but you need to be close with the manager. And you also really need to be close with, I keep using nursing staff as an example, but that's just based on my experience. You need to build credibility with the point of care or frontline staff that you're working with. And I think that something that's been really valuable in my experience is having that opportunity to be embedded and working within the hospital or within the health center, just stopping in on the unit and stopping at the nurse's station and having a conversation to build that relationship, stopping in at the clinical leader's office, just touching base to see how things are going, allows you to build that credibility and respect within the unit, which then is in combination with your partnership and support from more senior level decision makers. So I do think that there's multiple levels and multiple relationships that you need to build, which is why that recommendation that came out of some of those commentaries from the health system leadership study around, can you build a research program relationship? I think that's such a great idea, because then you can focus in on all the sub relationships that you need to support your projects.
All right, thank you. So 2 more questions so far. So first one says, thank you for sharing your experiences. I'm just wondering if during your education, did you happen to learn or come across quality improvement research? The KT model you used with your research sounds very similar to the plan, do, study, act cycle of quality improvement.
Yes, definitely. And I think there's lots of different models that take a similar approach. The knowledge to action cycle is a synthesis of many different planned action theories. So you would find a lot of similarities with it, with some different kind of planned action approaches. And I found that in my work, depending on who I was working with in the health system, they called it different things. And what I learned pretty quickly is that, you can't really get stuck when you're working with health system leaders and saying, okay, we're going to use this model and we're going to do this type of design and this type of focus group. You can have all of that clearly outlined, in your protocol and on your science page, but when you're interacting, you need to use the language that is most appropriate with teams. And so while it's very similar to the Plan, Do, Study, Act model, we were also embedding research questions within it so that we could use those findings to advance more of the science around implementation.
Great. Okay, and we have another question from Ellen. She asks, were the nurses and system leaders involved with the development of the research questions and methods in your example?
Yes, that's another great question. So the choose example that I gave really is kind of my go-to example when you think of something coming down the pipeline. And as I mentioned, the team said, okay, we got to get Christine in here because we're about to implement this, but maybe we should be following a more systematic approach. So in that example, I was, brought into a meeting room with nurses, physicians, and the system leaders, and together we mapped out a plan, including the research questions and methods. Again, not saying I wouldn't sit there and say, okay, what is your top research question? It's more, okay, what do you want to learn from this? What do you want to get out of it? And then from there, we would form the research question together. And we would discuss, okay, this is what you want to learn. What's the best way to do it? Should we be, doing a survey? Or they would often say, well, no, can you just bring all those people together like you do and ask them questions? So they're suggesting a focus group. And so that was a way that we together created our more formal research protocol. And in terms of that embedded KT question, that came really out of my postdoc work, so working in conjunction with my health system supervisor, academic supervisor, and the remaining team to understand, can we understand implementation in more detail so that we can use those findings for future implementation projects moving forward with this group.
Great. So we have a few minutes left. If anyone has any final questions, last-minute questions, you can always send them in via email afterwards as well. If you think of something afterwards.
Yeah, I'd be happy to chat more if anyone has any additional questions too.
Great. I will start some of my wrap-up spiel, and if anyone else has a question, we can skip back to that. But just want to remind everyone to please complete an evaluation. I sent out Word versions, and I also sent out a link to the online evaluation, and I'll resend that afterwards, just as a reminder. Our next session will be May 14th with Dr. Jen Tomasone from Queen's University, so you can keep an eye on our KT Canada newsletter and our Twitter feed for more details about that. And I think we're actually going to do something different this year where we actually have a session in June and July, which we don't usually, but I think we're going to do that this year. So keep an eye out. I think people might still be around in June and July, so we'll try it out and see how it goes. And I don't see any more questions coming in. So thank you everyone for attending and for your great questions, and thank you so much, Dr. Cassidy, for presenting with us today. We really appreciate it.
Thanks again for the opportunity. Really enjoyed it. Thanks everyone.
Thank you. Take care, everybody.